But oh, there we go. The meeting's being recorded. Thank you. Having a slick UX and, not really a ton of clinical heft to the programs. There's been more over the past few years, but really it was built around, hey, let's get some coaching, let's get some remote technology in people's hands and hope that generates some outcomes. More recently, there are some pretty good programs out there, but really until GLP-1s hit the news, a lot of those were focused on really single specific therapeutic approaches, like a specific kind of diet profile, or maybe the goal being to get people completely weaned off meds. And we, as a clinical entity, realize that these disease states are really not going to be solved by technology per se. They're going to have to be managed long-term by a provider community that hopefully embraces technology and is employing a full spectrum of therapeutic approaches that's really customized to the members. So that's what we're trying to solve for, is what's going on in cardiometabolics, but also what has the market done and maybe how can we do it a little bit better. So for those of you unfamiliar with us, Ochsner happens to be an academic health system with Center of Excellence designations and several different areas, including bariatrics, by the way. So this particular program came about because as at 35,000 plus maybe 38,000 lives, and as our size as an employer, and the fact that we are based in the New Orleans, Louisiana region, we had a very unhealthy patient base, as well as the same problems that every other large jumbo employer has. We also realized that the technology-based solutions out there just weren't really getting it done. And PCPs, of which we have quite a few, really have been the de facto center of care nationally for cardiometabolic conditions. Yeah, I know endocrinologists kind of are involved, but really, depending on what study you read, that's about 14% of the diabetic patients that are being seen by where they would consider an endocrinologist their primary point of contact to manage their condition. So the PCP community, both at Ochsner and just at large, really isn't well equipped to deal with these with these particular conditions. And so we wanted to build this to be, we decided to do this over 8 years ago. We wanted to build a better tech-enabled, provider-centric solution that was built to really augment the PCP care and most importantly, integrate with the patient's electronic medical record. So we launched it to our patient population in the region. That worked really well. We launched it for our employees. That worked really well. We launched it into some Medicare and Medicaid populations, again, mostly concentrated in the Gulf South. And we never really intended for this to be a point solution that was spanning across the country. But consultants started coming to us and word of mouth happened and asking us to roll this out for their clients. And then one thing leads to another, and we rolled it into a large national oil and gas company. And because we're establishing care and we're changing meds and we're establishing care in that way. So we had to go through the credentialing process for that. We thought, well, let's just take this nationwide and launch it in all 50 states. So we're not our whys do kind of matter in my opinion. And we're not trying to be a health tech unicorn. We're just trying to provide better care. So what is the program about? So it's not really rocket science. We are using remote monitoring tech, just like everybody else does. We're going to supply the cuff, the glucose kit, and all the supplies. If the patient happens to have a CGM, we'll set that up to integrate with our system. All the interface and communications are built around a slick app experience. So we have that UX there for the member. And so, that's where the coaching and the lifestyle modification support comes into play. It's all, built around that. But really the secret sauce isn't rocket science. It's every member being assigned a clinician. So that's a real important distinction. Every member, when they come in, they have a video visit with a clinician, and that is their clinician longitudinally. So if they're still a member 3 years from now, and they, their first interaction was with Dr. Jill or a PharmD named Blake, then that's their clinician. They still got the coaching team and all that stuff going on in the background, but they have a one-to-one clinician that they're assigned to. And that clinician is obviously watching their readings. We're managing the medications, so we're changing titration, dosage, all that good stuff, ordering labs as well. And again, it's all built around the Epic EMR. So every reading, the medication changes, all the encounter notes, it's all going to go into that patient's, MyChart, and it's available to their other providers. So this is the other bit of the secret sauce. We're the only ones, to my knowledge, I could be wrong. We're the only ones out there doing this kind of work nationally that has an Epic integration. Just the scale to pull that off, we're sort of fortunate because we're a health system, and so we built it around Epic, but we're the only ones that have that. So Rachel's going to talk a little bit more about this later, but just again, I sort of made a spoiler alert about mentioning Bob Diddy. I'm proud to say that we're in contracting with a relatively good sized Mercer client right now. And that Epic integration I mentioned, that was a really big deal to them. That was when we first met with them and mentioned that, the light bulb went off for her. She thought, okay, that was a really big aha moment. So does it work well? Yeah. Now, of course, every vendor has this slide, right? Everybody's got great results that they put on a slide like this. So what I will say about our data and the analysis that produced this, it's been validated, obviously, actuarially. It's been validated by the Validation Institute for whatever that's worth to you. But the main thing that I would mention here is that it was a book of business study using our Epic data and claims data. So this isn't the cherry-picked actuarial study of 3 clients. It was the book of business. And we're also, I want to note that we're not inferring future savings from event avoidance. So we're not, backfilling some, well, if we do X, Y, and Z, then there's 3 less heart attacks. We're not doing that. What we're proving out is that our members that were going to the ER 4 times a year are now not going to the ER. They were getting admitted to the hospital at a rate of whatever per year, and now hospital admissions are going down. So that's the kind of thing that we're tracking in our data. No meeting like this is ever complete, and I know I'm flying along, so blurt out my name if you want to stop and ask a question, but no meeting like this is complete without talking about GLP-1s. So I do want to just mention that our program automatically includes weight management. We became known, and we are increasingly getting known as hypertension, diabetes, sort of a 1-2 punch. Throw in hyperlipidemia into that mix as well. But our program is a bundle that also includes weight management. And really, if you think about it, since 40% of the population at large is obese, and depending on what you read, 30 to 40% of those people have diabetes, hypertension, or both. Even if it's only 20%, it's still a big number. And so it makes sense to have one care team, one provider team that can deal with that whole spectrum. So that's why we rolled this out as part of the program. We do follow the evidence-based guidelines around medication use. So some of the employers that we work with, they do cover GLP-1s for weight loss, and so we can just serve as the provider-based weight management program, and happen to be one of the prescribers of the medication. And some employers, they want to have a tighter restriction around that, or tighter gatekeeping around that. So this is what we did for our population. Remember, we're a 38,000 life employer, and we cover GLP-1s for our employees. And we set it up. We worked with our PBM to set it up such that if an employee at Ochsner wants to get a GLP-1 and they qualify on the 30 BMI, 27 BMI, evidence-based guidelines around that. If they want it covered, they have to be in our weight management program, so they have to be actively participating in that, and we have to be the prescribing MPI number. So that's something that we can do for other employers. I know that that's going to trigger a whole conversation around what the PBMs are going to have to say about that, and I get that it's not exactly like a magic wand that you can wave, but we can work with you and the employer around that. I will pause there because that usually generates questions. And again, I know I'm flying. Going once, going twice.
Blake, I'm just going to throw in a question that we oftentimes get from consultants and employers is, do we work with the PBM, or how does that work because our clinicians are the prescribers?
Do we work with the PBM? Yeah. So we are just, well, I'm stumbling over my words. So what we did with our employee base is we communicated we set it up with our PBM so that they have to be, when the step therapy, for lack of a better term, they're going to check, hey, are you participating in a weight management program? Yes. And we can verify that because they're participating in the program. We can do that for any employer. And then we are the prescribing entity. And we set that up directly with the PBM. I think that was your question.
Yeah. And one thing we always point out too is it's just like going to a brick and mortar to your PCP or your primary care physician. We're prescribing just like they would. So it's no different. We don't do anything in regards to the formulary changes when it comes to, you as a consultant working with your employer. We're completely separate from that.
Another question that we get a good bit is, what if the client wants to follow other BMI protocols? Like, for instance, bariatric surgery, I think, I'm going from memory, I think a lot of employers set up if they're going to cover bariatric surgery, I think the BMI is like either 40 or 35 or something like that, and they want to sort of translate that approach to this. We're not going to do that. So if that's the goal, we're not going to be a fit, because we're going to follow the evidence. And the historical evidence around this is that 30 BMI, 27 if they've got a weight-related medical problem, that's the sweet spot, and that's what we're going to follow. So again, we're sort of handcuffed is the wrong word, but you being providers, we're not going to abandon a provider approach to this.
And it also helps with the PBM conversation, being that we're not limiting prescribability. You're still giving it to anyone that is clinically eligible. So that's some of the pushback that we've seen in implementing some of these.
Yeah, for sure. There's a chat. Let's see. Health assessment address emotional mental status. What's your exclusionary criteria? Rachel, you're good at the exclusionary criteria.
Sure. So it is individual assessments, and not only for weight management, but our whole cardiometabolic program. We start with social determinants of health, but also do clinical individual assessments. So yes, it does include emotional mental status. Actually, part of the exclusionary criteria that those two questions tie in together. One of the exclusions would be if someone has an eating disorder, for example. We would not consider them clinically eligible for a GLP-1. Another example, and some of these are extreme, but if someone's on a transplant list, we would not want them to be a virtual patient. We believe that member needs to be seeing their doctor face to face. One other example for you would be someone that comes to us that is pregnant, that has high blood pressure. We believe that a pregnancy should be with the OBGYN. We would advise that member that they should see their OBGYN through their pregnancy, and if they still continue to have high blood pressure, come back to us after the pregnancy, and we would of course work with them. So that's just a few examples for you. I don't know if anybody has any other things to add to that.
And yeah, she said thank you. And the exclusionary criteria is always going to, like, if you read the Wegovy insert, there's a few acronyms on there, and I can never remember the condition. And I've said it out loud like 500 times, but PERS or something like that. But anything that's listed in those inserts, that's as an exclusionary criteria for the drug, we're going to follow that. Good questions.
This is Prachi. How long is the first prescription for, and how often do you evaluate? Do the clinicians evaluate the patient? Is it just GLP-1 or non-GLP-1 weight management drugs?
So the clinician is going to decide on the best treatment program for that particular patient. So this is absolutely not a one-size-fits-all program. This is going to be customized to every member. And just to kind of put it in perspective for you, the minute someone enrolls in this program, they become a patient of Ochsner. So, the clinician is treating them as a patient, not necessarily a member of a health plan or anything like that. So it would be like any other provider relationship. But if they meet all of the criteria to be eligible for the GLP-1, I believe the first prescription is usually for a 3-month period. And that clinician is going to be in touch with that member as well as monitor them along the way. We're going to ask for weekly weight reportings, as well as diet and exercise logins, just making sure that that member is active in the weight management program. We don't want someone to just enroll. We want someone engaged and actively participating so that we can monitor everything that's happening. And there is certain criteria at that 3-month mark, which I'm sure you all are familiar with, but there is a certain percentage of body weight that should be lost by the 3-month mark. There's another higher percentage at the 7-month mark. So part of this program is that monitoring, where someone is constantly looking at the member, seeing where they stand, and if this medication's not working for them, taking them off of that and doing something differently. So many people what we found are continuing these medications, just hoping and praying that it works, when it might not work for them. Just like any other medication, it doesn't work for everyone that takes it. Does that answer your question, Prachi?
Yep. Thanks.
This is Stephen. I have a follow-on, actually a couple of follow-on questions, but one directly related to that. Is there an intentional goal to wean people off medications at some future point in time?
Overall, yes. We don't know what that looks like at this point, just because it is so new for weight loss. These medications have been around for quite some time, but the indication for weight loss is fairly new. So that is the goal, is to, and why the weight management portion of the program is so important, because we don't want this to be the easy button for people. We want people to have the behavior modifications and to be coached and held accountable for those behavior modifications along with taking the medication. So, the titration of the program or the medication will be according to their tolerance and how they're doing. And same way with coming off of it, hoping to wean people off eventually. But we just don't know what that looks like yet. We don't know if that's going to be a year or, but we just don't know. And it's probably going to be case by case.
That is a perfect world. Obviously, that's a perfect world outcome, but I'm a little, how do I say this in a PC way? I'm a little skeptical of programs that are saying things like, oh, within 12 months, it's going to be weaned off. Like, I don't think any practicing clinician out there that's like seeing patients every day, if you ask 1,000 of them, you probably get 1,000 different answers as to what the best approach is in terms of weaning off. Like Rachel said, it's still way too early, and we are always going to default to what is best for that patient in the moment, rather than tick a box with an employer RFI that says, do you have an 18-month wean off kind of goal? Until such time as that becomes supported by the evidence, then that may be a different answer in the future. But just like Rachel said, it's too early for that.
And I think that's a good point. There's a lot of experimentation going on right now, and that leads to my next question, which is, do you have any mechanisms in place to try to mitigate the waste? I just spoke with someone that has 8 different vials in the refrigerator. So with the shortage of some medications, they were prescribed something else. Now they've got 8 different vials that are on something new now. That's a lot of cost and a lot of waste. Do you have any mechanisms in place? And I guess the other overarching question that you can infuse into that is, do you have specific guidelines that all of your prescribers are following? Because it sounds like it still might be, even within an organization, somewhat of a Wild West and trying to figure out what works best.
To my knowledge, go ahead, Blake.
Well, on the waste thing, I don't know the answer to that. Rachel, do you know that?
No, I don't. That's what I was gonna say. I don't either. That's the first time we've gotten that question, but I'll write that down.
We're gonna follow up on that so that everybody has our answer for that, because we don't want you to not have that answer. I'm sure that's a problem that we're experiencing already. So we'll have to find out from the care teams how they're handling that. Great question. And then what was the part 2 of that again?
And part 2 is, are there specific clinical guidelines? And this sounds like that's the yin and the yang of individualization, right? And we know that it's an art in the science of medicine, right? So we're still trying to figure all that out. And I guess that's where the variability always adds to more cost and different outcomes. And that's what we're wondering is, how do you manage the variability in patient experiences and patient outcomes?
I can share with you that our position organizationally, like our clinicians would tell you that the overwhelming evidence supports the fact that GLP-1s are the most effective, when supported by behavior modification change. It's the most effective method. Of course, not every employer covers it, so obviously we've got to be sensitive to what the employer allows. But in terms of the clinical approach, if it's available to the employees, that is going to be in the conversation, but it will be a conversation with that plan member. Maybe they're afraid to make injections. So we may say, hey, what, based on your BMI and your other, criteria, GLPs, and your employer covers this. Is that something that you are willing to do or you're interested in? And they may say, no, I don't like needles, or whatever the case may be. Or I have 10 friends and they all hated it, whatever. So that's going to be a conversation. So it's first understanding that the evidence supports that GLPs are the most effective. And then it becomes then the care model is just like it would be in a brick and mortar clinic. So our clinical approach for that team, it's not just willy-nilly doctors within our system. These are not moonlighter doctors that are on our team. It's Ochsner Connected Health. They're Ochsner doctors, but they're devoted to this program. So they're not an ER doc on Wednesdays and in this program on Thursdays and then back to ER on Friday. So that's the approach is understanding GLPs are probably the best method, but they're not for everybody, and having that conversation. And then wherever that leads at that point. So that would be sort of the clinical flow.
And I'll add one thing to that. Because these clinicians are focused on just these conditions, they are all keeping up. They all have the same training. They're all keeping up with the latest guidelines, where many of our own primary care doctors said they had a hard time doing that because primary care has to know so many things about, just conditions across the board, where these conditions are focused on cardiometabolic disease. So they are specialized in this, particularly in just keeping up with all of that. So many of them are practicing very similarly, but of course, everything is case by case when you're dealing with human beings.
Now, I'll reiterate again, if anybody really wants to go deep with Dr. Cole's very accessible. He loves talking to consultants. And so I would encourage you to take advantage of that, because even if he's going to approach it from a clinician perspective as opposed to selling Ochsner, it would be well worth your time to spend a little time with him and get his perspective. It might be a unique lens into this world versus some of the the other kind of vendor-based solutions out there. Great questions. Thank you, Prachi and Stephen. And I think Carolyn had a good question there. Feel free to ping back with others. These are great conversation. We're 30 minutes in here. So I'm going to kick it to Rachel to talk a little bit about client fit, do some demo, and we can talk about pricing.
Yeah, so if you don't mind, let me share my screen. I'll start with the demo
sure.
first.
Stop share.
Thank you. Let's see if I can get mine to work as easily as you did. All right, can everyone see that?
I see your screen.
Okay, perfect. So this is just a brief demo of enrollment that we wanted to share with you. What does the employee experience and what does the employee see? We do work with you guys on your employer clients to set up customized marketing campaigns, and we put customized QR codes on each piece of marketing materials that we provide you with, so that we can track those analytics. We know how people are signing up for the program. We know what's working and what's not. But when an employee scans that QR code, this is what they see. This is the screen that it takes them to. And as I believe Blake mentioned earlier, because we're a provider-based solution, we do have to establish care on the front end. So you'll see the path that this demo, this enrollment demo takes you through on providing their information, but also signing them up for that virtual visit, which is the first step to entering our program. We want to be sure people are not only eligible for the program from an employer perspective, but also are they clinically eligible for the program. So that's what that virtual visit is that each employee would experience on the front end. Once they get past that eligibility criteria, that's when we would send out devices and assign the care team, and that member would start in the program. And just so you know, that virtual visit does not cost anything to the employer. That is part of just our process on verifying eligibility on the front end. So an employee scans a QR code, and this is the screen that it takes you to. So you input your name, email address, phone number, and you want to sign up for digital medicine. So we do ask, verify that you're 18 years or older. So this program is available to dependents, spouses, and or dependents that are 18 years and older. Someone will have to have a device of some sort in order for the Bluetooth devices to connect, and the Epic integration and all that good stuff. And then, of course, provide verification of identity. So you put in your address, male, female, birthday, and then click on your employer. This is where you would usually put your social security number. We do ask for a roster file in the beginning during implementation, the initial roster file, so that we know who is eligible for the program. We do build an Epic profile for each person that could potentially enroll in the program, so that when they input their social security number here, we are able to identify them and verify their eligibility. So now we know who they are, and we have to confirm their identity. So pretty easy, upload a photo of your driver's license, which most people know how to do these days. Take a picture of the front and back, add that. And then we continue. So what are your health goals? And assuming the program includes all of these things, which it normally does, weight management, we're gonna go through all three just so that you can get the experience of it. So we have all of these issues. Which ones are you interested in? You check those boxes. Put your height and weight. And are you interested in GLP-1 medications? This question will not be here if your employer does not offer GLP-1s. This is only going to be here if that is available on the program. And the criteria that Blake mentioned, the 30 BMI or 27 with another comorbidity. The third criteria would be, I'm already taking a GLP-1, because there's a possibility that someone might have a BMI of 28 that would typically not be eligible, but their BMI is 28 because they're currently taking a GLP-1. So we want to be able to assist those people as well. These are all the consents, just like anything you sign up for these days, you have to sign your life away a little bit. This is how to measure your arm for the blood pressure cuff that we would be sending to the home. And this question here is asking about a continuous glucose monitor. We are able to support these both of these continuous glucose monitors. So if they do already have that, we will send them the glucometer that we send to everyone, just so they have the finger prick device, but we can also support this as well. We're going to do the shipping address to make sure we're sending devices to the correct places. And this is where you schedule your virtual visit, or the video consultation as it's called here. So you choose the date and time. We're going to do 10:30 on the 24th. And you can add this to your calendar. The member will also get a text message 10 minutes prior to that video consultation where they can just click on a link and it will bring up the FaceTime, or I'm not sure if it's FaceTime or another application, but it's one of those. But they will get a text message as a reminder so that they can have that virtual visit. But that is basically the enrollment process. Any questions on that?
Just a question about matching. So you're picking your own time. So essentially, you're going to be connected with whomever is available at that time, right? Is there any kind of matching between patient and provider that goes on? I'm thinking from a health equity lens, different identities, ethnicities, and concordance with provider and patient. Any of that happening?
Well, I know on the front end, we would make a note if we do have, for example, a high Hispanic population where we need Spanish speaking availability, we would have all of those notes on the front end. That is a good question. I don't know that we are asking that on the front end. Alyssa or Blake, do you know if we're able to?
Meaning, are we asking in the enrollment process before they're matched with a clinic?
They're met with a clinician, and we do have a language line that we use. So if for some reason that call does occur, I know the clinician or the physician in this case, it's always a physician on this first virtual call. The clinician that's assigned after the fact is state by state, depends on the state requirements of who has the credentials and availability to fill prescriptions and that sort of thing. But
the other element of Stephen's question is around, like, for instance, capturing, do you have a preference around LGBTQ or racial identity, that sort of thing. So that's I think would be an interesting thing to take back to product.
Yeah.
I'll make a note of that. And that may be because the product team, Stephen, is like they are devoted to this program, and it's a constant refresh. They're not just firing and forgetting. So that's a really good note. I haven't personally seen in their latest roadmap of that being captured before a clinician's assigned. And again, it's sort of, as Rachel said, you got to be licensed in that state. And so there are obviously limitations around that. But that's an interesting note to make.
And Blake, do you want to pull your screen up again? I'm going to.
Yeah, sure. Screen. Oh, hang on a second. Oh. Well, you'd think I can, but stand by. Here we go. I gotta move this over. All right. There it is. I think we're back.
Perfect. Okay. Did you want me to cover this one as well, Blake?
Sure. You're on a roll.
Okay. So this is, just simple. What is the perfect fit for this Ochsner program? Obviously, self-funded employers, we're typically targeting 1,000 plus. That's kind of our threshold. We do have a smaller group option if needed, but I know you guys typically focus in that larger market anyway. And then obviously we want a fully committed employer. If an employer is not willing to let us do the marketing of this, if people don't know about the program, it's hard enough to get people to take care of themselves. So we want to be able to get the message out there for people to understand what the program is. We want to be in that client's ecosystem, whatever that might look like. Maybe it's a navigation solution that they use, or they use a care management program currently, or maybe they even have some sort of on-site or near-site clinic that we can work with to funnel those folks that are targeted with one of these conditions. They can funnel them to us as well, so that we're able to help them manage their conditions.
The other, real quick, just to double click on the fully committed thing. So a lot of, I'll just be real with y'all for a minute. When we resonate with a lot of employers just because of what we talked about, the Epic integration and being the only provider-based solution out there. And sometimes what happens is they really like this program, and they think, oh, we're going to leave our, they've got one of the legacy providers in the space, and ultimately inertia winds up winning. because, oh gosh, I don't want to go through contracting, or gosh, this, we have got something that we could just check a box with United and get a diabetes program. In my mind, that's, if they're going to continue down that path, they're not really committed to change or solving the problem. If they were not excited enough about their current program to want to go through the time and energy to check other stuff out, and then they're just going to default to what they've been doing, the definition of insanity and whatnot. So, we're obviously, we can't predict the future, and I'm not trying to say don't send us opportunities, but we get most excited about the employers like the one that we're working on with Bob Didi, that like, no, we have, I'm not going to say who they're coming to us from, but they have another legacy provider, and they're like, no, we want to really get some clinical heft into this thing. And so, yes, we're willing to do the work to get it, to make a move. And so that's the kind of energy that we're looking for. So that's all I'll say about that.
Yeah, and just to go into that a little bit more as well, we're able to provide the solution to employers in all industries. There's very few industries that aren't suffering with cardiometabolic diseases being at the top of the utilization reports. But having said that, we have seen, really good results with certain industries versus other. Many times the white collar industries are more of the people that are sitting at their desks and can really interface with that virtual aspect of it. But there's also blue collar industries that they're on the road and they're unable to see a doctor all the time. Many times they're able to work with us really well as well. It's not always easy to enroll the blue collar industries, but once we get them enrolled, they really are engaged. So we have less than 2% attrition in our program, and it's a matter of getting people to the program. Where I mentioned that customized marketing, if we can get people in the program, we know that we can engage them because they love it. Our NPS scores are really high. We have great feedback from our members, but it's getting people to the program that is sometimes the issue. Another thing I wanted to mention, we just started doing a white label solution for health systems. Many health systems sometimes don't want another hospital's name on their product. So we are working on that. That is going to be available for 1/1. So we do have that capability as well, where we can white label the app, white label the whole experience so that it doesn't appear that another health system is providing these services. And these are just some of the takeaways. We mentioned most of these already, but when you think of our program, remember that we are a provider-based solution. We have designated clinicians that are working with these members where they gain the rapport with these members. People feel accountable. They truly like working with a person that they can speak to on a pretty regular basis. And, when we take a look at this program, having that connectivity, you get to know your provider just like you would in a face-to-face scenario. Having that Epic integration is a huge differentiator for us, and we are able to drive information and patient information back to primary care doctors across the country. So very important to note that as well. We are doing true medication management, being that we do establish care on the front end. We're ordering lab work. We are able to provide prescriptions as well as change prescriptions. So what else? We can also be that GLP-1 gatekeeper. So if you have a need for that, that's kind of top of mind for everyone these days. And if you're providing it, if you're not providing it, do you need some guardrails around the GLP-1s? We can certainly help with that. And so far that we've dealt with this year, every single case has been a different scenario. So we'd be happy to talk with you through those scenarios.
Let's talk pricing.
Go ahead, Blake. I'll hand it back over to you.
So we price on a per engaged basis, and it's consistent across all the conditions. So if Blake presents to the program and gets in, and I'm just hypertense, it's $65 to the employer per month for me, as long as I'm engaged. If I have hypertension, diabetes, and I'm in the weight management program and getting GLPs and the whole ball of wax, it's still $65. So very consistent, easy pricing, and no increase. No increase for managing multiple conditions. implementation fee, we don't always, just a note about implementation fees, we don't always charge them. But sometimes we do, just because of the nature of the situation, what the client is looking for in terms of customization of materials and that sort of thing, or just the difficulty of integrations and whatnot. So we don't always charge them, but on average it's around $5,000-ish, and that's kind of a one-time sort of thing. We don't do like an ongoing administrative fee. It seems kind of silly. So we try to be super easy to work with on that regard. We get asked a lot of times, well, what do you call an engaged member? And when do you drop them off the bill if they stop engaging? And what does engagement mean? So engagement means they're interacting with their coach, they're submitting readings, whether it's weight or their glucose, that sort of thing. And if we're messaging them and if we're trying to get them to engage with us, we just ask the employer for 90 days. Sometimes I'll give you an example. And we do have this happen occasionally, where somebody will enroll, they'll do the video visit, and we'll send them, say, a blood pressure cuff, and then never hear from them again for any number of reasons. And we're going to try, for at least 60 days, and starting at 90 days, that's when they're coming off the bill. So we do try for a few months to get them to re-engage, but at 90 days, that's they're going to be coming off the bill, because we shouldn't be charging the employer for somebody who is engaging with us. So again, we just try to be easy to work with on that regard. We're here kind of at the end. Any questions? We've got a few minutes left, but happy to give you all some time back, or if you have any questions that we didn't answer before, happy to get into that. I have some homework that I wrote down. So we're going to confirm that 90-day is the default position on prescribing GLPs. I think, Stephen, you asked that question. So I'm pretty confident in Rachel's answer, but I'm not beyond 99.9% confident of it. So we're gonna definitively answer that. I'm gonna look into the waste mitigation. That's a fascinating question. So I can't wait to see what we're thinking about there, and then get with the product team around matching SDOH or DEI matching with on the clinician side with new members coming in. I think that was a really interesting question as well. Was there anything else that we need to be looking into, or anybody want to throw out if you're thinking about any clients, feel free to check with Bob Diddy. We're knee deep in contracting with one of his clients. So we'd love to have more opportunities to just be an alternative. But most of the big clients out there, they have something, a legacy vendor. If diabetes, hypertension is still a problem for them, like why not show them some alternative that's provider based? It's when you're coming from a not-for-profit health system, that's a very, very different why. And we tend to resonate with people. We're not going to be for everybody. We're not going to be perfect, but I think we're a really, really solid alternative.
I've got a question around the upfront integration with PBMs in terms of catching members. So if you're the sole prescriber, but if a member ends up going somewhere else and they get a prescription, do you have those process integration with PBMs, catching them at the pharmacy or whatever, or through a PA process, and then looping them into the Ochsner program?
All right, so let me restate your question, make sure I've got, so I'll just use us as an example. So an Ochsner, like let's say I want a GLP, but I'm not participating in the Ochsner weight management program. And I do the whole, I go to see my PCP down the street here in Atlanta. And she says, all right, Blake, yeah, you qualify, I'll write the script. And then I go to fill it. Our PBM is going to, like, when I go to fill that prescription, they're going to say, oh, no, you can't do it. Is your question at that point, is the PBM coming to us to say, hey, you didn't fill this prescription, can you reach out to Blake?
Yeah, so it's a couple points. Are those um, connection points already established, especially with the main PBMs? Sometimes they are points of friction. And then how well does that experience look and feel like from a member's perspective?
Yeah, super honesty here. So we've established that with our PBM, which is not one of the big three. We do not have like a signed agreement with the big three on like a deep integration at this point. Frankly, they're not interested in that sort of thing because they want to develop their own programs around this kind of stuff. Our stance has been, if you have a client that's with the big three and they want it to happen, if there are 1,000 lives, it's probably going to be difficult for them. They're not swinging as big a stick as, say, a jumbo employer might. We will integrate with anybody. We've got no problem on our end on the technology side or the technological integration, but there will always be resistance from the big three because they want to capture all that themselves. I don't think they're well equipped for it, but so that'll be something that we have to work through. And sadly, as of this point in time, to answer your question, that's going to have to be a case by case, which I know is not the ideal answer, but it is what it is. I'm in talks with 2 other PBMs that are kind of more on that transparent, up and coming side. They don't have the market share that the big three have, and they really like what we're doing, and so we're talking to them about the contracting piece. And so I think over the next 12 months you'll see a lot more of that from us in terms of maybe the not big three PBMs, which maybe that puts pressure upward. I don't know. So I don't know that I fully answered your question or not, but it's kind of the state of things at this point.
Thank you.
Mm-hmm. Good questions. Any others? And on that, just I guess sort of double clicking on it. Ian, I think that was you that asked the question. If anybody wants to deep dive with the actual clinical team, happy to set that up. Lift the hood and check it out. Because you're just getting my answer on that, but I think it might be worth a conversation, especially if you have somebody in mind. Client or whatnot, and you think, oof, this is going to be a potential problem to even bring this up. Let's set up a conversation. Great question, John. And you got just a few minutes left. We can give you some time back, or if there's any other questions. Well, thank you, Patty, for your support in setting this up. We appreciate the Mercer team very much. Reach out to Rachel, Alyssa. You can always reach out to me. I think my name is all over VIP. And you know what? As you're looking in VIP, I'm always in there tinkering with it. So if you see something like, I wish he talked more about this, or I wish they had this bit of material in there, shoot me a note. I'm happy to. I want to make sure that we are putting the kind of information in there that you need from us. So feel free to give me feedback around that.
Well, thank you, Blake and team. That was very informative, and we really appreciate it.
Appreciate your transparency.
Yeah. Thanks for the time, y'all.
Thank
All
you.
right. Have a good weekend.
Thanks, everyone.
Thank you.
Take care.
Bye.